We still have another 3 minutes. Regarding recording, you are most welcome to do any recording of my teaching, whatever I am narrating. There's no reservations, please, if you need to do it. In my lecture, I give you the link for the YouTube, because previously I recorded the lecture. So you may use this previous recording, but you may do recording anytime, just at your convenience. I absolutely don't mind. So today is one of the most complicated lectures in the whole CNS module in anatomy. So please, let's just try to understand and remember as much as possible. This is very important. Cranial nerves are regarding all sorts of activities in the face and in the head and even beyond. For example, vagus nerve. It controls the stomach, intestines, kidneys, spleen, so many other organs. So really, the range of activities within the 12 cranial nerves is enormous. And you're supposed to remember it by heart. You're supposed to remember 12. You're supposed to remember their names. You're supposed to remember their branches and their functions. And what is most complicated will be course of fiber. Course of fiber is so sophisticated, just cerebral. So of course we'll not go into small unnecessary details. But as usually, I would like you to focus on the clinical issue. Whenever I say clinical implications, it means this is the most important, and this is 100% will be included in your exam. And another thing, usually when you pass your professional exam, you proceed with the clinical year, and then you reach neurology, and you don't remember cranial nerves. The neurology lecturers become so angry. So please don't make them angry and don't make me unhappy and try to remember cranial nerves. This is very important. Whatever specialty you choose, you will need to be able to somehow understand the symptoms which come from the cranial nerves, or 12 cranial nerves. I think we can start now. So today we will be talking about first cranial nerves, first 6 cranial nerves. 1, 2, 3, 4, 5, 6. And we identify foramina through which they leave the skull, because they all originate in the brain. It means inside the skull. But they need to come out to control certain functions in the face and head. That is why they need opening. We need to remember this opening. Then we need to remember the nuclei. What are the nuclei? The nuclei, every cranial nerve is having its origin, which is a nuclei. And nucleus or nuclei is a combination of the bodies of the neuron. So we will see that most of the cranial nerves, they have the nuclei, and besides some of them are having even more than one, like 2 or 3 or even 4 nuclei. And we need to remember. Then we also discuss the function of them and the course inside the skull, outside, and of course most important is the clinical implication. So these are the cranial nerves from 1 to 12. Today we will be only considering first 6. Okay, this one. And this is the picture of the brainstem. The lecture on the brainstem will be next Thursday. But for the time being, just remember that in the brain we have large hemispheres and we have the brainstem, which includes the midbrain, pons, which is pons like a bridge, and this is medulla oblongata. So only these 3, they will give rise to all cranial nerves. All cranial nerves have nuclei in either midbrain or in the pons or in the medulla oblongata. And easy to remember this diagram, how to remember the origin of each and every cranial nerve. So cranial nerves 1 and 2 originate from the cerebral hemisphere. Cranial nerves 3 and 4 originate from the midbrain. Cranial nerves 5, 6, 7, 8 originate from the bones. And cranial nerves 9, 10, 11, 12 originate from the medulla oblongata. Very easy to remember. And let us start with the cranial nerve 1 or olfactory nerve. You're supposed to memorize both the number of cranial nerve 1 and the name. Name is olfactory, means dealing with the smell. So first of all, I would like to explain that some of the cranial nerves are purely sensory. You understand what is sensory? Sensory means for the sensory input. It means receptors outside and fibers send these inputs to the brain. This is sensory. Motor is for the motor output. It means that nucleus will be somewhere in the brain and the fibers will go to the periphery to innervate muscles and the periphery. For example, I'm smiling, I'm opening my mouth, watching this. This is motor innervation of my muscles of the facial expression, which are innervated by the facial nerve number 7. And some of the nerves are mixed. Mixed means they have sensory fibers and motor fibers both. Some are purely sensory, some are purely motor, some are mixed. But another important thing for you to understand that besides we have autonomic nervous system. We have sympathetic and parasympathetic overall. But in the brain there is no sympathetic. Sympathetic centers are all in the spinal cord, not in the brain. In the brain we have only parasympathetic. This is important to understand. So we'll be considering 3 types of fibers: sensory, motor, and parasympathetic in the cranial nerves. And they're all intermingled, interconnected, very complicated. But I will try to make it as simple as possible. And the last important introductory thing for you to understand is that once we have motor fibers, we have motor nuclei. Once we have sensory fibers, we have sensory nuclei. Once we have parasympathetic fibers, we have parasympathetic nuclei. And then parasympathetic nuclei will give rise to the preganglionic fibers. Preganglionic fibers, which will be parasympathetic because they originate from the parasympathetic nuclei. But then there will be a ganglion. We will consider each and every ganglion. And from the ganglion there will be postganglionic fiber. Postganglionic fiber, which also needs to be parasympathetic. Otherwise, the organ will not work. For example, our lacrimal gland will not be able to weep, to produce tears once we don't have parasympathetic fibers. But lacrimal nerve doesn't have parasympathetic fibers, so how? So it's quite complicated, but we will consider each and every detail. And we start with the olfactory nerve, which is a purely sensory nerve, cranial nerve number 1. So this nerve, it starts in the nasal cavity. You can see this is the nasal cavity, and this is the roof of the nasal cavity. And here we are having so-called olfactory mucosa, which includes the olfactory epithelium and then the propria. And here we have the cilia. Here are the cilia. These cilia will recognize the smells. What are the cilia? The cilia belong to the neurons. So here they are. Olfactory cells are neurons. They are bipolar neurons. Bipolar means that there is a body and there are 2 processes of bipolar, 2 processes. One is peripheral, which ends with the cilia, and another is central, which goes to the brain. So total we have, let's say 1, 2, 3, 4, maybe 6, maybe 8 neurons, which, except the sense of smell, in the nasal cavity. Then they send impulse through the central process, and here these axons or central process will form bundles. And total will be 1, 2, 3, 4, up to 20 bundles. And then this bundle will go through the lamina cribrosa into the cribriform plate. This is cribriform plate in English, lamina cribrosa is the Latin. It goes through the openings in the lamina cribrosa to the anterior cranial fossa. And here it will be synapsing with the second neuron. Here it is, the body of the second neuron. It is here. So, and these neurons will terminate in the olfactory bulb. In the olfactory bulb. So, olfactory bulb is having bodies of the second neuron. And second neuron is also having axons which go up to the senses of smell. Sorry. Yeah. Here it is. So you can see on this picture, once again, this is the cilia in the nasal cavity. Here the neurons, the axons enter the brain. And this is the ventral side view of the brain. This is the brain stem, this is the midbrain. And this is so-called olfactory bulb and olfactory tract. So here in the olfactory bulb, we have the process of the second neurons. And here the first neuron will be synapsing with the second neuron, but it is no longer olfactory nerve, because olfactory nerve ends in the bulb. Of course, there will be second neuron, which will be sending axons to the olfactory tract, to the centers of smell, but it doesn't concern with the olfactory nerve, which is the cranial nerve number 1. So please remember that the cranial nerve number 1, olfactory nerve, ends in the olfactory bulb, full stop, which is taken over by the olfactory tract, but we are not considering it today. Next is optic nerve. Optic nerve is cranial nerve number 2, and it deals with vision. It is also purely sensory. No motor, no parasympathetic, only sensory. So here you can see this is the eyeball, isn't it? And this is the retina. And here in the retina we have so-called ganglionic layer, and the neurons of the ganglionic layer send the axons, huge amount of axons. This is 1,200,000. Can you imagine? So these fibers will form the optic nerve, cranial nerve number 2. And you can see that this cranial nerve, it exits eyeball, but not in the very center. You see, this is the axis, but this is the location of the exit of the nerve fibers of the optic nerve from the eyeball. And they will enter the cranial cavity through the optic canal. This is optic canal. And total length of the optic nerve is 4 centimeters. 25 is in the orbit, 5 millimeters is in the optic canal, and 10 millimeters in the cranial cavity. And here in the cranial cavity, the 2 optic nerves, right and left, will fuse together to form optic chiasma. Very important structure, optic chiasma. And then here, some of the fibers will cross to the opposite side and some will not. This is very important for the vision, that some fibers do cross and some do not. And then after that, after chiasma, this is the beginning of the optic tract. But this is no longer optic nerve, because optic nerve ends at the optic chiasma. This is important to understand. So if the nerve is damaged before chiasma, somewhere here, what will happen? This is complete loss of vision. Let's say trauma or tumor or whatever. This will be complete loss of vision. But the optic nerve may be affected at the level of chiasma, or it may be affected after the chiasma at the level of the optic tract, and you need to be able to diagnose. This is very important. Please try to understand. So this is the cause of the fibers. You can see that this is, you understand that we have a field of vision, isn't it? And we have a so-called temporal half and nasal half, right and left accordingly. Okay? So here on this picture, this is right, this is left. Nasal halves are shown by the red color, and temporal halves are shown by the blue color. So you have a patient who will attend your office and will complain that he lost temporal vision. You can only see, of course you can see, you still can see, but some folks only can see through the nasal vision, and temporal visions disappear. This is a very serious symptom, because most likely this will be the tumor of the pituitary gland. Exactly. How do you go? Okay, absolutely correct. Why? Because look at this picture. So first of all, you understand that the image which gives retina is reversed, isn't it? So that is why you can see that the lateral fields, the impulse comes from the received by the nasal fibers, okay? And then nasal fibers, they run in the optic nerve, and then they reach optic chiasma. Here at the same time we are having pituitary gland, and here you can see that some fibers cross, blue fibers cross, and red fibers do not cross. So that is why if we have a tumor of the pituitary gland, then which fibers will be affected? Blue color, isn't it? So blue color, where do they go? Here, here, yes, you see? Exactly. So please, this is very important to remember this term. This is bitemporal hemianopia or hemianopsia. This is, both terms are correct. Bitemporal hemianopia. Bitemporal means both right and left lateral fields disappear. And this is a very serious symptom of the possible tumor of the pituitary gland. Then what will happen, for example, if there is damage to the optic tract after optic chiasma? What will happen? You see, once again, here is lesion or whatever, inflammation or tumor or just trauma, also possible. So here we see this is, interruption will be here. So this is red color, it goes here, and this is blue color, it goes here. So what does it mean? It means there will be loss on both sides, on the right and on the left side of the contralateral fields. So if it is right optic tract which is affected, then there will be loss of the nasal left and temporal left and nasal right. And if it is on the left side, then what will happen? What will be the loss? Right will be lateral or temporal, and left will be nasal or medial. Exactly. So this is very important. Okay. So for the time being, try to remember, but of course try to comprehend. Because one thing, if you memorize, you forget. But if you understand, you don't forget. So this is very important. Whatever specialty you choose endocrinologist or, I don't know, general surgeon. But you see the patient and he is complaining of the loss of the field of vision, and you need immediately to understand what is going on and take action. This is very important. Then what will happen after that? After that, fiber will go to the lateral geniculate body, and then for the optic radiation, and then to the visual area 17 in the occipital lobe. But once again, is it optic nerve? No, it is not. Optic nerve, cranial nerve, two ends at the optic chiasma, and it is a purely sensory nerve. Is it clear so far? This is very simple, I tell you. The subsequent nerves are much more complicated. But regarding these local fields, 100% there will be questions during your OB and also at your professional exam. This is compulsory because it's really important. So now we are taking nerves 3, 4, and 6. Don't be surprised why we are taking these 3 nerves, because they all deal with the movements of the eyeball. So we can look up, look down, isn't it? Right, left. See, so this is beyond, this is within our control. It means this is somatic postulation, and it is innervated by the motor nerve. That is why these nerves 3, 4, and 6 will be motor nerves, and they will be dealing with the movements of the eyeball and also with the movements of the upper eyelid. But unfortunately not all, there will be something else. But okay, let us first deal with the motor function. This is the picture. Okay, I skip it at the back. This is the picture which is hated by all students. I remember how I hated this picture when I was a student. Okay, I will get back to it later. So, this is, once again, pulse, isn't it? What is this? Great. This one? This one? The lava exactly. So, cranial nerve 3, or ocular motor nerve. It originates from the midbrain. Here it is, from the ventral surface, because this is ventral surface. Okay. Cranial number 4, it is called trochlea. It also originates from the midbrain, but from the dorsal side. You see? Third from the ventral, and fourth comes from the dorsal side. Okay. And cranial nerves number 6, which is called abducent nerve, doing abduction, is originating from the pons, but in the groove between pons and medulla oblongata. This you need to memorize, as I told you earlier. 3 and 4 midbrain, 5, 6, 7, 8 is 6, 7, 8 is from the pons. But now we are only considering 6. For the time being, we skip 5. Cranial nerve 3, oculomotor nerve, it continues in the middle cerebral fossa, and it lies at the lateral wall of the cavernous sinus. I hope you remember cavernous sinus. Remember, I presented you this picture. So here they are. This is the oculomotor nerve at the lateral wall, cranial nerve number 3, trochlea number 4 also at the lateral wall, and abducent is inside, number 6. This is optic chiasma. Remember, I told you this is optic chiasma and this is pituitary gland. So remember, as we agreed earlier, once we have a tumor of the pituitary gland, this will affect optic chiasma and optic nerve, isn't it? But if, let's say, the patient doesn't complain, because he still can see, isn't it? Then, which nerve is next to be involved? Oculomotor, exactly. He will not be able to move the eyeballs. Then, it still continues to grow. What happens next will be trochlea nerve, exactly. And then, but most likely it will not reach occlusal nerve. This is unlikely. So most likely is oculomotor and trochlear, but provided the tube is big enough. But usually, of course, the patient will complain because he will be scared. For example, he's driving a car and he will not see, you see? So definitely he will complain and he will take action. I think this what is this? Rhomboid fossa, okay? Rhomboid fossa is partly belongs to the pons and partly belongs to the medulla oblongata. This is cerebellopeduncle, superior cerebellum peduncle, medial and inferior cerebellum peduncle. And this is the floor of the rhomboid fossa. But this will be another lecture, no need to remember this. This is just for your overall understanding. So now we are looking for the nuclei of the 3 cranial nerves. 3 is oculomotor, 4 is trochlear, 6 is occlusal. Exactly. So this is the midbrain, this is epiphysis, and this is superior colliculi and inferior colliculi. Okay. So cranial nerve number 3, oculomotor nerve, will be having its motor nucleus at the level of the superior colliculi. While cranial nerve number 4, trochlear nerve, will be having its motor nucleus at the level of the inferior colliculi. And from here there will be fibers, motor fibers, red color, I will show you, which will be running towards the eyeball, because we need to make very complicated movements by the eyeball. So yes, this is first nucleus of the oculomotor nerve, red color at the level of the superior colliculi of the midbrain. And nucleus of the but we have parasympathetic. You see, cranial nerve number 3 is having parasympathetic nucleus, which is called interstitial or in part, or by the name is nucleus of Perlia. Perlia is a letter, P-E-R-L-I-A, Perlia. And 2 nuclei which are called accessory or Edinger-Westphal. Edinger-Westphal. Here it is, there are 2. So interstitial is 1, Perlia is 1, and the accessory or Edinger-Westphal is 2. Also at the level of the superior cranials. So this one is motor nucleus because it is red color, parasympathetic is green color, motor is red color, and the nucleus of the fourth nerve, trochlear nerve, is at the level of the superior colliculi on both sides, right and left. And finally, cranial nerve number 6 or abducent. We go to the pons. This is rhomboid fossa, the floor which belongs to the pons, and this structure is called facial colliculum. Don't be surprised, because here we have 2 nuclei. This one, like a comma, is a facial nerve. We'll leave it for the next lecture. And this dot is for the abducent nerve. But overall, it's called facial colliculus. Though the name is not quite correct, because 2 nuclei contribute, but somehow you see there are many unfair things in anatomy and other sciences. So now we go to the muscles. And here above the eye we have 2 muscles. One is levator palpebrae superioris. Levator palpebrae superioris. This muscle will open the eye. And G2 is superior rectus. Superior rectus muscle, which will be sending the eyeball up. Then below here we have inferior rectus, which will be sending the eyeball down. Besides, we have lateral rectus and medial rectus. lateral rectus and medial rectus will be doing abduction and adduction accordingly. And besides, there will be oblique muscle. Oblique is superior, here it is, and inferior. So total, all the movements of the eyeball and upper eyelid will be controlled by 7 muscles. I repeat, superior rectus, inferior rectus, lateral rectus, medial rectus, 2 oblique muscles, superior and inferior, located medially, and levator palmatory superioris. So these 3 nerves will be controlling these 7 muscles. How will they do it? But not to forget parasympathetic, you see. So now let us see the course of the fibers. This is superior orbital fissure, okay? All these nerves will exit the brain, or better to say, it's coming out of the skull through the superior orbital fissure. Here it is. So from the midbrain, these fibers will be running through the superior orbital fissure towards these muscles. Let us see the course of the fibers. You also can try to make this picture, then you will better understand and better remember. Yes, here it is. So this is oculomotor nerve. It is coming out through the superior orbital fissure and will be divided into 2 parts, 2 subdivisions, superior and inferior. And superior will be innervating levator palmatory superioris and superior rectus. While inferior ramus or division will be innervating, here it is. What is this? Inferior rectus, this one. Inferior oblique, and this one, medial rectus, exactly. So it means one nerve will be controlling 5 muscles. Superior division, levator palmatory superioris and superior rectus, and inferior division, inferior rectus, inferior oblique, and medial rectus. So we still have another 2 nerves, 4 and 6, trochlea and abducens, and we still have 2 muscles. What are these muscles? Yes, here it is. You see, this is trochlea nerve, which is sending fibers to the superior oblique, and abducent is sending fibers to the lateral rectus. Can you imagine? One nerve is innervating 1 tiny muscle. Can you imagine? Does it make sense? Most likely yes, because isn't it? Being is a perfect creature of God. So this is how it goes. But besides, we have parasympathetic. I remind you, these 2 are called accessory or Edinger vestibular. Edinger vestibular. And this one is in part, or it is still interstitial or central. And by the name, it is nucleus of Perlia. Perli. So what will happen here? You see, these parasympathetic fibers, nuclei, are sending fibers to the ciliary ganglion. And ciliary ganglion is parasympathetic. And from here we have short ciliary nerves, which approach eyeball, and what will they do? Once it is parasympathetic, it is something beyond our control, isn't it? We can move eyeball, but we cannot perform voluntarily our parasympathetic function. So what are these 2 functions? Number 1 is constriction of the pupillae. Okay? So here it is, these short ciliary nerves will be supplying the muscle, which is called sphincter pupillae. Sphincter pupillae will be constricting the pupil. So once you see that, let's say, one of the eyes of your patient is, pupil is narrow, but another eye is wide, you need immediately to understand what happens. It means sphincter pupillae muscle is paralyzed, okay? And it cannot constrict. Even let's say you send very bright light to the eye, there should be constriction, isn't it? But it doesn't happen. It means this is the problem with the parasympathetic fibers of the oculomotor nerve. And another function is ciliary muscle. Do you know ciliary muscle? Sure. Okay. So what will happen if ciliary muscle is paralyzed? What is the outcome? Impossibility to focus, isn't it? For example, let's say if ciliary muscle is contracted, that's what will happen. Then what will happen to the zip ligament? It will be relaxed, isn't it? And the lens becomes round and we can read, isn't it? But if ciliary muscle is relaxed, then what will happen? Then the ligament will be stretched, the lens becomes flat, and we can view, I can see the students at the back row, okay? I can see the faces of the students at the back row. So if it is affected, if the fibers are somehow damaged, then what will happen? Inability to accommodate, inability to focus. And the vision of play cannot read even using my spectacles, you see? Because spectacles do not help. You need accommodation. So this is all for this picture. Once again, I remind you, please remember this is superior orbital fissure, this is ciliary ganglia, this is preganglionic fibers, which are parasympathetic. This is postganglionic fibers, which are short ciliary nerves, and they control accommodation and they control constriction of the villi. While dilatation of the villi will be sympathetic, but we are not studying it today. So next. You understand, this is the sagittal section, this is the eyeball, and here you can see this is all the muscles. So this is, what is this? Superior rectus, this one above, levator palpebral superioris, this one cut, lateral rectus, this one, inferior rectus, this one, inferior oblique. And this is the nucleus of the oculomotor nerve. And this is oculomotor nerve, shown by the blue color. Yes. This one is fourth trochlear nerve. Here it is, as I told you earlier, it will be coming out from the dorsal side of the brain stem, and it will innervate only one muscle, which is superior oblique. And the abducent nerve will be innervating. This is the only muscle, which is lateral rectus. So this is the summary. I don't have much time. Please look through and try to remember as much as possible. This is the summary for the trochlear nerve and for the abducent nerve. So this trochlear nerve, sensory, motor, or mixed? Trochlear nerve, is it a sensory nerve, motor nerve, or mixed nerve? What is its function? I repeat the question. What is trochlear nerve? Is it sensory? Optic is sensory. Olfactory is sensory. Oculomotor is contracting muscle. Of course it is motor. How can it be sensory? Sensory means information about perception to the brain. There's no information. So obviously trochlea is absolutely purely motor. Abducent nerve, which is only abducting the eyeball, supplying lateral rectus muscle. Is it sensory, motor, or mixed? Sensory? No, of course not. Motor? Yes. Mixed? No. Yes, of course. Trochlea and abductor are purely motor nerves. Supply only one muscle. Trochlea is superior oblique and abductor is lateral rectus. How about oculomotor? Is it sensory? Oculomotor? Of course not. Sensory is olfactory and optic. Full stop. Oculomotor is obviously motor because it is supplying muscle. One muscle that is motor. You see, setting the eyeball up and down. But you have parasympathetic. So can we call it mixed? Actually not. You see, somehow by the using term mixed we mean sensory and motor. One that we call sensory, we call oculomotor is a motor. Though we keep in mind that it is not purely motor because it is having parasympathetic fibers to do constriction of the pupillae and to do accommodation, to do the control of the ciliary muscle. So once again, what is this muscle? Superior rectus. This one? Yes, this one inferior. This is inferior rectus. This one? Lateral rectus. This one? Medial rectus. This one? Superior oblique exactly, which is supplied by the trochlea nerve. By trochlea, this is the trochlea. You see, this is the force of the fibers. So here the view from the top. This is the eyeball. What is this? Levator palpebra superioris. This one? Superior oblique. This one? Trochlea. Okay. So this one? Lateral rectus. This one? Medial rectus. Inferior oblique is not shown. Another interesting thing that all the rectus muscle, so this is the equator of the eyeball, okay? This is the visual. So this is the equator. All rectus muscles, superior, lateral, medial, inferior, they are attached in front of the equator. Here it is. That is why if the muscle is contracted, what will happen? It will be pulling the eyeball toward itself. So once superior rectus is contracted, where will the eyeball go? Up. If inferior rectus is contracted, the eyeball will go down. If the medial rectus is contracted, the eye will go medially. If the lateral rectus is contracted, the eye will go laterally. Towards itself. Simple, isn't it? But oblique muscles is different. Oblique muscles, superior and inferior, not shown here, are attached behind the equator. It means they will not be pulling, they will be pushing away from themselves. So it means if superior oblique is here and it will be pushing away from itself, what will be the direction? Down and lateral. If inferior oblique is here, medially, it will be pushing away from itself where upward and lateral. Exactly. Very important to understand, to be able to get it. So this is once again the movements of the eye, easy, isn't it? Lateral rectus, eye goes laterally. Medial rectus, eye goes medially. Very simple. But while going up and down, it becomes quite complicated. Try to look up. Right, don't move your head. Look straight. And now don't move your head, just try to look up as high as possible. Are you comfortable with this movement? Not. Exactly. Why? But if you look not directly up, but laterally and up and laterally. Are you comfortable? Yes. Why? Because you see, everything is so complicated, isn't it? Because when you look up, we involve two muscles, superior rectus and inferior oblique. You see, because superior rectus doesn't pulls just up. It pulls up and medially, while oblique is sending up and laterally. And there is a conflict between these two muscles. That is why we feel pain. Now please look down. As down as possible. Are you comfortable?
No.
Sure? No. Try to look down and laterally. Are you more comfortable? Yes. Why? Same problem. Because this is not only inferior rectus which pulls the eyeball down, but again two muscles. Superior oblique which is pushing away from itself, and inferior rectus which is pulling towards itself. These two muscles again conflict with each other and feel uncomfortable. So this is important to understand. So this is what I already explained to you. Superior rectus, lateral, medial, superior oblique, inferior rectus. These are the result of their activity. Now tell me very quickly, what is this? You see, this is your patient. He is complaining, let's say he's having pain in the back. But you see this picture. So what is this? This condition which is called squint or strabismus. Please remember, both terms are correct. Squint or strabismus. And then maybe he was born with this malformation. But maybe he developed it yesterday, isn't it? And then this is a symptom. So now please diagnose what is this. Please diagnose this condition. What is this? This is squint. This is deviation of the eyeball medially. It means which muscle is paralyzed. Yes, you are showing absolutely correctly. Which muscle is paralyzed? It means the eye cannot go laterally. Once it cannot go laterally, it means which muscle? Lateral rectus, exactly. Once lateral rectus, which nerve? Three nerves: oculomotor, trochlear, abduction. Lateral rectus is abduction because it's abduction, isn't it? Okay, so it means the diagnosis is paralysis of the lateral rectus muscle due to the damage to the abduction nerve. This is the diagnosis. Okay. So this one, what is this? This is also squint or strabismus, but deviation is different. The eye goes upwards and medially. So which muscle is paralyzed? It means it cannot go down and laterally. Which muscle sends the eyeball down and laterally? Trochlear, exactly. This is trochlear nerve which innervates which muscle? Superior oblique. So this is diagnosed will be paralysis of the superior oblique muscle due to the damage to the trochlear nerve. Absolutely correct. How about this one? This is again the problem with the left eye. Right is normal, and you see the upper eyelid cannot go up. Okay, see here by finger you put it up, but otherwise it will be like this. So immediately we can say what is this? Which nerve puts the eyelid up? Oculomotor, exactly. What is the muscle? Levator, palpebral, superior, correct. But remember, we agreed that oculomotor is the most complicated because it supplies 5 muscles plus parasympathetic, constrictor pupillae, and accommodation. So this patient, what could be other manifestations of this damage to the oculomotor? One is upper eyelid goes down, number 1. Number 2, what will happen with accommodation? 3. What will happen to the pupil? Is it narrow or wide? To make it narrow, we need to do constriction of the papilla. And the constrictor papilla muscle is innervated by the oculomotor nerve. But here oculomotor nerve is damaged. So what will happen? Constriction is not possible. So the pupil will be wide. And how about deviation? You see, once all muscles are paralyzed, except 2. Because remember, we have 7 muscles. 5 are paralyzed, but 2 are not paralyzed. Which are not paralyzed? Those innervated by other nerves. What are other nerves? Trochlea and abducens. It means whatever muscles are innervated by oculomotor, they are paralyzed. But those which are innervated by trochlea and abducens, they are not paralyzed. So they will be controlling the movement of the eyeball. So what is the function of the abducen? Nerve to innervate lateral rectus, which will send the eyeball laterally. So it means in this patient, the eyeball can go laterally. And another nerve is trochlea. It is not paralyzed. And trochlea is, which is, what is the muscle? Superior oblique. Superior oblique is sending the eyeball superior oblique away from itself. Downward and laterally, exactly. It means the only movement of the eye in this patient is either laterally or downward laterally. Full stop. It cannot go up, cannot go medially, and so on and so forth. Is it clear? Yeah. Okay. By the way, this condition where the eyelid goes down and cannot go up is called ptosis. Okay? So please remember ptosis. While if the pupil is wide and cannot constrict, this condition is called mydriasis. So please remember, this is important. Strabismus was twins. Number 1, this is deviation. Then ptosis, the eyelid goes down. Mydriasis, the pupil is wide, and no accommodation, severe muscle, oculomotor nerve, parasympathetic fibers. Another interesting symptom is diplopia. The patient will complain that he can see the object double. Okay? So what does it mean? What is the mechanism? The extraocular muscles of the eyeball in a sympathetic manner to move the eyeball. Therefore, patients rarely present with an isolated injury to the trochlea nerve. So, diplopia or double vision usually signifies trochlea nerve injury, particularly in the lateral gaze. The patient will say that if I look forward, there's no diplopia. But if I look laterally, then I get diplopia. So this is manifestation of the damage to the trochlea nerve. And this clinical presentation occurs due to the superior oblique muscle being hindered from assisting the inferior rectus muscle in depressing the eyeball when the eye is in the abductive position. Okay? So please, another symptom regarding these 3 nerves is diplopia, which is associated with the trochlea nerve. Please remember. So I skip the summary. This is the quiz. Please make a picture of the left-sided paralysis of the abducent nerve and left-sided paralysis of the trochlea nerve. And now we go to the trigeminal nerve, which is most complicated. After my lecture, what is your class? No class. Sure? Okay. Do you mind if I take some more time? For this nerve is very complicated. But it is very important. Just remember that the trigeminal nerve is the main sensory nerve of the face and head. So whatever sensation we have from our face and head, this is pain, temperature, pressure, touch, all comes from the trigeminal nerve. it doesn't mean it is sensory. No, it is mixed. We also have motor, but motor is not too much. But sensory is just comprehensive. So this is quite very important because there are so many symptoms. For example, corneal reflex. You know, you touch the cornea, but the patient doesn't blink. What does it mean? Trigeminal nerve. So trigeminal nerve originates from pons. Here you can see two roots. One is bigger, another is small. Lateral is bigger, medial is small. So lateral is sensory or motor. What do you think? Once lateral is bigger, look, you see this, quite thick, and this medial is small, thin. So is lateral sensory or motor? It's sensory. Remember, we agreed that trigeminal nerve is the major sensory nerve. All sensations from the head, from the lateral gland, from the tongue, from everywhere will be trigeminal nerve. So that's why motor is big, while sensory is big, while motor is quite small. So what will happen here? This nerve will exit the pons and get into the posterior cranial fossa. Okay? And here from the posterior cranial fossa, it needs to come out to innervate the outer structure. So first it will pass through this is temporal bone, and this is petrous part of the temporal bone. So this nerve, it came out in the posterior cranial fossa. Then it will cross petrous part of the temporal bone and get into the middle cranial fossa. And here it will form impression on in the middle cranial fossa, on the petrous part of the temporal bone, which is called trigeminal impression. Trigeminal impression. Why impression? Because here it will form trigeminal ganglia. So here it is. This is pons. This is posterior cranial fossa. This is petrous part of the temporal bone. This is medial cranial fossa. So what happened to this yellow color is sensory or motor? Big one. Sensory of pons. This is the main sensory nerve. So this yellow sensory is coming out from the posterior cranial fossa to the middle cranial fossa. And this red, small one, this is motor, also coming out from the posterior cranial fossa to the middle cranial fossa. And here, the sensory part is forming trigeminal ganglia. Trigeminal ganglia. What happens to motor? It will not. It will not contribute to the trigeminal ganglia. It will just pass by. And then it will divide, trigeminal ganglia will divide into three parts. One branch is ophthalmic branch. Ophthalmic branch which will exit brain from the superior orbital fissure. Then second is maxillary subdivision. It will come out through the foramen rotundum. And the third one, mandibular, will come out through the foramen ovale. You need to remember. You see, this is what they will ask you. What is the point of exit? So I repeat again. For the ophthalmic superior orbital fissure, for the maxillary is foramen rotundum, and for the mandibular, foramen ovale. But here, after that, after coming out through the foramen ovale, sensory fiber, yellow one, and red one, motor, they will mix up and they will run together. Sensory will be sending impulse to the brain, motor will be sensory impulse away from the brain to the periphery, but they will be running all together. By the way, as you probably understand, cranial nerve number one, what is the name of the cranial nerve number one? No nuclei. Then optic nerve, pure cerebral hemisphere. Number 3, ocular volta, does it have nuclei? Yes, the mid-brain. How many? 1 motor and 1.5 parasympathetic. 1 whole accessory and 1 half interstitial. So here, trigeminal nerve is having 4 nuclei. Yes. So what is this? Rhamboid fossa. This one belongs to the pons. This is midbrain, superior cariculi, inferior cariculi, and this is the first blue color is sensory. The first sensory nucleus, which is called main or principal. Main or principal. It runs in the floor of the rhamboid fossa, part which belongs to the pons. Because this triangle belongs to the pons, this is the lumbar. Then from here you have another nucleus, which is quite long, you see, and it goes towards the midbrain. You see, quite big nucleus, long, and not only in the pons, but it will be reaching the midbrain. And the name is mesencephalic. Mesencephalic nucleus. Number 3 is also sensory, because remember, trigeminal nerve is the major sensory nerve. We have 3 nuclei. Also the big one, you see, it goes towards medulla. And it is called the nucleus of the spinal tract or spinal nucleus. So main, mesencephalic, and spinal. The 3 sensory nuclei to innervate sensory sensations of all face and scalp. And only 1 motor, you see, it is also in the floor of the rhamboid fossa, in the part which belongs to the pole. What is this? Facial colliculus, just above facial colliculus. It is called just motor nucleus of the trigeminal nerve. But not so many, because mostly trigeminal nerve is for the sensations, all sorts of sensations. So please remember this nuclei. So this is a beautiful picture of the ventral part of the brain. What is this? What is this? Which cranial nerve? Olfactory nerve. This is olfactory bulb, and this is olfactory tract. What is this? Optic nerve, exactly. This is optic chiasm, and this is optic tract. What is this? Ocular motor, exactly. This one? Trochlea, exactly. This one? Abducens, exactly. And this one is the trigeminal. You see how big it is. And these are the 3 branches. Number 1 is ophthalmic, which is purely sensory. Number 2 is maxillary, which is purely sensory. And number 3 is mandibular, which is mixed. It is sensory and motor both. And fibers are mixed up. What is important? We do not have a parasympathetic. No nuclei, it means no presympathetic fibers. But later on you will see, for example, lateral gland is innervated by the trigeminal nerve. But to make lateral gland to produce tears and weep, we need parasympathetic. Where do we get this parasympathetic? One, there's no nuclei and no preganglionic fibers. And how come? How can lateral gland get parasympathetic? From other nerves. From other nerves which have parasympathetic. But this will be post-ganglionic. So please, another interesting thing regarding trigeminal nerve is though it doesn't have its own parasympathetic preganglionic fibers and no parasympathetic nuclei, but all parasympathetic nerves, all parasympathetic fibers which run in the head and face, they are all associated with the branches of the trigeminal nerve. How? Because they will be added to the postganglionic fibers. Ganglionic fibers. No parasympathetic, postganglionic fibers will get parasympathetic from the nearby cranial nerves. That is why lateral gland, which is innervated by the trigeminal nerve, still having parasympathetic innervation. Because it will borrow postganglionic parasympathetic fibers from another nerve, which I explained later. So this is to demonstrate what I mentioned earlier. You see, this is trigeminal nerve. Yellow color is sensory. Purple color is parasympathetic. You see, for preganglionic, no purple, no parasympathetic. But postganglionic are having parasympathetic. For example, this is Ellington-Westphal nucleus. See, and it has parasympathetic fibers which run to the ciliary ganglia. Ciliary ganglia is a parasympathetic nucleus. Here we have postganglionic fibers which run towards the pupil to do constriction of the pupil and to do accommodation. Okay? So let's say all other nerves, you see, for example, this is the submandibular gland, sublingual gland. They are also innervated by the trigeminal nerve, but it doesn't have its own parasympathetic fibers. That's why it will borrow parasympathetic fibers from other nerves. So now I need to explain this very bad, very unfriendly picture. So this is embryology of the brain. As you probably remember, here we have alar plate and basal plate. And alar plate is for sensory, basal plate is for motor. So what we already know is cranial nerve 3, oculomotor, cranial nerve 4, this is trochlea, they originate from the midbrain, and cranial nerve 6, which is from the cortex. So what is this sensation? This is somatic efferent. Somatic efferent. It means this is within our control, because definitely we can control all the movements of the eyeball. Okay. So next is this one, let's say, this black color. Black color is parasympathetic. Remember I told you Ellington-Westphal or accessory nucleus for the oculomotor nerve to supply constriction of the pupil and accommodation of the eyeball. What is this sensation? It is called general visceral efferent. General visceral efferent. And this also originates from the midbrain. Okay. So next is special visceral efferent. Special visceral efferent. Here it is. This is regarding the trigeminal nerve and other nerves, which we are not considering today. This will be, for the facial nerve, this will be another lecture. So, and what is important is special visceral efferent. Special visceral efferent is this blue color. This is for the skeletal muscle of the first branchial arch. Do you remember branchial arches? Okay, more or less. So please remember, it's important that this will be supplying the muscles of mastication. What are the muscles of mastication? Remember, this is masseter, then temporalis, then lateral pterygoid and medial pterygoid. Full stop. Only these four muscles, muscle of mastication, they are considered muscles of the third branchial arch and they are innervated by the trigeminal nerve. Please remember. And besides, not so many. Mylohyoid, anterior belly of the gastric, posterior belly will be facial nerve. Anterior belly is trigeminal nerve. Tensor tympani and tensor vellopalatine. That's all. mylohyoid, anterior gastric, then certified, then certified. Okay? So once again, I repeat, this is fifth cranial nerve, trigeminal nerve, and this is so-called special visceral efferent sensations for the trigeminal nerve. And besides, what is important for the trigeminal nerve, as I mentioned, this is for the mounting, not too much, isn't it? It is just small part of the mandibular nerve. But sensory is huge, and we have several nuclei. One is, what is this one, which is in the midbrain? Mesencephaly. Then in the pons is main, and in the medulla is spinal. Mesencephaly, main, spinal. They belong to the general somatic afferent. General somatic afferent, it means mesencephaly will be in charge of proprioception of the temporomandibular joint. So this is mesencephaly. Then main sensory will be for touch and pressure over all structures of the face and scalp. And finally, spinal tract will be for the pain and temperature. So this is important to understand. Okay. So I skip this because probably you are already tired. Okay, so shall I continue or you're already tired and it's useless? Right? Otherwise, I cannot the rate of the trigeminal nerve next time, because next time we have complicated facial vegas. There was a pharyngeal cervical. So this is only one chance of it to stay there. Or you will do it yourself, you will just have it recording. Remember, in your notes which are uploaded, there is a link for the recording of the trigeminal nerve. So shall I do it now, or you just use this recording? You use recording because you are tired and you don't comprehend anymore. Okay, so if there is a problem, with the link, then send me a message and I will WhatsApp the link. Okay? You can WhatsApp me anytime.